deep plane facelift is something that I did almost exclusively probably 15, 20 years ago. And I came from the sub-smash family where we, basically did a nice sub-smash that extended into the neck and gave us like very, very nice neck results. The original deep plane, as described by Dr. Hamra, involved separating the ligaments, which freed up this malar fat pad right here. And by moving the malar fat pad back, it opened the nasolabial fold. And that was the major distinct advantage of the deep plane over the former sub-smash facelift. And because I was sometimes unhappy with how these folds got better or didn't get better, I should say, we started using the deep plane. But the problem with the deep plane was that the neck dissection was limited, the way Dr. Hammer described it. And so my neck results really didn't seem to be as good as I was getting with a sub-smash facelift. And so the evolution there went to, well, why can't we do what we do in a sub-smash in the neck and combine it with the upper portion of the deep plane? And so I evolved into what I call a hybrid facelift, which is the deep plane in the mid face, and it's a sub-smash everywhere else. And once you connect that ligament, once you connect the cutaneous mesenterocutaneous ligament and you sever that, you connect the deep plane with the sub-smash. The rest of it in the neck is the same, and so you get the same kind of neck results. I'm
sorry, I'm going to interrupt you as we go along, but I've seen some of these patients with these deep plane neck lifts, and they look severe. They look like you had what's called a radical neck, which is a very, very like this,
Right. Right. So what you're referring to is not a deep plane in the neck, but it's the neck dissection that occurs depending on what they have in their neck. So, some patients really have no fat in their neck. Their submaxillary glands, the salivary glands, have not dropped or they're not enlarged. Their digastric muscles are not very prominent. And they might not have much subplatysmal fat. And those patients do really well with just a sub-smash facelift. And sometimes I don't even open up the neck at all. And they do well. And that's a smaller subset. I would say that might represent maybe 15%, something like that, 20%, where we don't touch the neck at all.
Mm-hmm.
Most people—
Those are young patients, though, typically,
they're
right?
usually young, but they can be older too. I mean, they can be older and they just have that anatomy where the digastrics are tucked away and they really don't have a lot of facial fat and not much subplatysmal fat. So but the thing is this, is if you really look at these necks that are a little bit obtuse, a lot of people think it's subcutaneous fat. And in reality, I've stopped almost removing subcutaneous fat. Because what I find is that the significant contouring piece is this little T-shaped piece of subplatysmal fat. And if you get that piece out, then you're left with a decision of whether the digastrics are contributing to that sort of blunted neck, because people do want a more sculpted neck. Now, I agree, when you take out the submax glands and you take out the digastrics and you take out the subplatysmal fat in the majority of patients, some of them can look a little over-sculpted, It's an interesting look. It's an interesting thing. It's not
interesting look. Is it something that that the surgeon wants, or is that what the patient wants? Is the question.
See, it's a very interesting question, because there's no patient that comes to me and says, I want this kind of, sculpted look. But the corollary is that when you do it, sometimes I think, gosh, I don't think I needed to do that. And I will tell you that I'm kind of backing away from taking more submax glands out for a separate reason, but I'll get to that.
Okay.
But I think that that I haven't had many patients complain about it. In fact, they love it. You know what I mean? It's like,
really?
It's an interesting thing. Like when I look at it, I think, is this really necessary? Is it really what the patient wants?
Yeah.
The patients don't know what they want. They're not asking for that specifically, but they do like the idea that they have a better neckline than perhaps they've ever had.
Okay.
And I find that. So my process here is that if I think there's some subplatysmal fat, I'm going to look at it. I'm going to remove the subplatysmal fat, being very careful to preserve the interdigastric fat because you
Yeah.
don't want to dig the neck out.
Right.
And then we remove that down to the hyoid. I like to kind of
Mm-hmm.
skeletonize the hyoid so I have a good point of fixation. The key is not to remove a lot of platysma so that you have a nice platysmal flap that you can cover all this stuff so it doesn't look excavated, if you would.
Right.
And then we take out some digastric if it's necessary. And all I do is basically look at the digastrics. And if I can take an instrument and lay it across the mandible like this, and the digastrics don't pop below it, I don't touch them. If they do pop a little bit, I just look at it and say, oh, that's hanging down a little bit. And I'll just strip a little bit of the digastric till I get the contour I want.
Mm-hmm.
So it's like sculpting the digastric.
But do you tie the digastrics together? Do you suture them together? You don't do that anymore.
I don't
Because
do that.
a lot of people said they got away from doing that.
Yeah.
And by the way, just for the public's knowledge, the digastrics are muscles right here, right below our chin.
Right here, and they kind of go down just a little bit like that. And you can see them sometimes at the end of a facelift, and they look a little prominent. And when you just kind of shave them down a little bit, this contour is a little bit better. There are people whose salivary glands, which are a little further back, are very, very prominent. And in those patients, sometimes you just can't get away without taking a little bit, like the outer shave of it. And by doing that, they're not as prominent. Sometimes it's asymmetric; it's only on one side. But I also have to factor in that when they're present but not super prominent, that when you do the platysma, when you do the muscle work and actually pull the platysma back, if you do your release of the muscle in an appropriate way, and then you suture that back, that helps tuck the glands up too. And it is
I mean,
pretty
that's an old
impactful.
technique. That's an old technique, isn't it?
It's an old technique. I mean, it's something that I've done for years.
Mm-hmm.
I do think it works, and I do think it works over time, because people will say, you'll get an immediate improvement, but you won't get a long-term. And I disagree with that. But I also think that there's a place to remove the submax glands. And I think that it's a little bit more often than you think. I used to think I had to do it in half the cases. I think now it's about 25%, where I do some submax modification that brings it in line, whether it's one side or both sides. And I just think the necks look a little better. I think if you're taking the submax glands out in 80 to 90%, I think it looks a little bit sculpted, a little bit overdone, because a little fullness there is not objectionable to the patient. If they're really ptotic, they will complain about that afterwards. But think about all the facelifts you've done, Joel, where how many times have they complained about their submax glands post-operatively? Maybe 10% of the time, 15 at max.
But they don't know better though.
No, I know, you have to educate them as to what it is. Yeah, for sure.
Exactly. They don't know. They think that's great. I mean, if you look at probably most of the old textbooks where they were showed good what they consider to be good results, you always see some
submax gland, right?
I call it submandibular glands. I don't know. You call them submax.
But so the other thing is, what you asked me about is, like, do you use a deep plane for everything? And the answer is no. It's just I have a decision tree that I use that's really not based on the neck, because the neck to me is the same. I treat the necks all the same. And so, I mean, when I say I treat them all the same, I treat what's there. And I use a platysmal flap. I use a platysmal transposition flap in all cases. So it depends on what's in the submandibular contents, the submental contents, I should say, that makes it different from case to case. But as far as doing a platysma plasty and doing a lateral platysmal pull with a transposition flap, I'll do that whether it's a subsmass operation or whether it's a deep plane operation. And so the way my decision tree is about whether I do a deep plane or subsmass really depends on midfacial ptosis. So if the nasolabial folds are really deep, the orbital rims are exposed, we have significant midfacial ptosis. In those cases, I'm going to start with a subperiosteal mid-facelift.
Oh,
And in those patients, I don't do a deep plane because it's too
oh,
much dissection in the face. So I already have taken care of what I would do with a deep plane in a way that I feel is better than a deep plane. And in those patients, I'll do a sub-SMAS. So I'll do a subperiosteal mid-facelift combined with a sub-SMAS. Then there's those patients who have midfacial ptosis that's not as severe. They might have deep nasolabial folds, but the orbital rim isn't so exposed. The SOOF hasn't dropped very much. And the SOOF is that fat right under the eye that drops. It's not the orbital fat, but it's below that. And if that hasn't dropped very much, then a deep plane will efface the nasolabial folds better than a sub-SMAS. So in that patient, I won't do a mid-face, but I'll do a deep plane. And that represents probably 40%, 40 to 50% of patients where in the past I might have done a mid-facelift, but now we can get by with a simpler operation and just do a deep plane.
mm-hmm.
But when you have severe midfacial ptosis with these sort of very exposed orbital rims, I love to do a subperiosteal mid-facelift because it gives you great orbital fullness. At the same time, it really effaces the nasolabial folds